done a good assessment, then only we can do a good surgery. And if we have done a good surgery, then complications are few and far in between. But whenever we have complications, we should know what to expect and what to do. So I come to my presentation and to do the ICL and a toric ICL the correct way. So how do we do it the correct way? We do. So in the correct way of doing an ICL, the importance is to the technique. You need to see this technique on the YouTube video, understand, and have a supervisor around with you when you're doing your first cases. The first thing is inject this cartridge has to be filled with BSS and methyl cellulose. And if you have filled your cartridge nicely with methyl cellulose and BSS, then that's the first step. There should not be any air bubbles in the cartridge along with the BSS. Why? Because when you're pushing in the ICL into the anterior chamber, these bubbles might obscure the view of the lens and the unfolding of the lens. Everything is important on the unfolding of the lens, because if a lens has unfolded the right way, the job is done. You don't need to worry. If it has folded the wrong way, everything is a mess. So you take out with this applicator, it's a special applicator from the BSS Plus housed in that small bottle, some small vial, and place the ICL under the microscope on the cartridge where that part is there to house the ICL. And you have to use this particular applicator. Do not use a forceps or anything else to tweeze it in. Once it is lodged and the convex side is upwards, then what you need to do is to pull from the opposite end with a special forceps supplied by the manufacturer. It's called the Osde forceps. And you have to grasp the ICL where the hole is just paracentral to the optic zone. This has to be done under the microscope, and the grasping of that hole, that is actually a significant hole, and if you grasp it at that place, then you have the right hold of the ICL. If you have grasped it far behind, then you might be pulling too much on the ICL. So once you have grasped it and drawn the ICL to the nozzle, then it is ready for use. And then what you need to do is to clip it into the injector, and the clip is very sound, and once clipped, the forceps is out and you need to push through the applicator which is there. Next is making the main port. You've made the side ports. They should be approximately 1 to 1.2 millimeters. The main port should be 3.2 millimeters, should not be more than 3.4, and should not be less than 3.2, because there should not be any struggle putting in the nozzle into the anterior chamber. The nozzle has to go into the anterior chamber, and once the nozzle is there in the anterior chamber, it's a gradual push, and under vision you have to see the unfolding. And the most important marker at this point is the leading right haptic. That has a small mark, and you have to see that the leading right haptic is going the right way on the right hand side. Next is the tucking in of these 4 haptics under the iris, which is quite simple. But as you can see in the right hand lower side, there was a little bit of constriction. So you have to be very gentle, use adequate amount of methyl cellulose, and that's the methyl cellulose is the viscoelastic of choice, and tweeze it in very, very gently. If the pupil is constricting, you need to put in more methyl cellulose and it will open up. Once there is an adequate opening, and never do an ICL if it is a mid-dilated pupil. So washing and clearing of the viscoelastic is very important. Everything needs to be taken out. The irrigation aspiration cannula can go in and sit very close to the central haptic port. And from this central haptic, the central hole on the optic, which is 360 microns, the egress of the viscoelastic comes out. So if you can direct your irrigation on the central optic, the hole, then what happens is from the side, the viscoelastic under the ICL comes out, and you have a total clearance. And as you can see that the marks are there, and you have to align it to the aligned marks that you have made on the toric marker. Once this is done, it's very important to understand that everything is out, the viscoelastic has come out, and you have a well-settled ICL. When it is these ICLs in BSS Plus, next day when you are seeing the ICL, the vault is exactly what is going to be permanently. And only if there is excess viscoelastic, then only the vault might change. And otherwise, this is the amount of vault that you can expect post-operatively. And as Purendra very correctly said, that the vault is the most important thing and is dependent upon how good an assessment you have done, whether your measurements were correct, the white to white was correct. So the other thing that you have to note post-operatively is the intraocular pressure. And as you can see, that it seems that the central flow hole is a little directed towards the temporal side, but this is not true. Why it is not true? Because our pupils are actually eccentric and directed on the nasal side. So this is something that you have to keep in mind when you're seeing post-operatively. This is not a decentered ICL. The other thing, of course, that you need to check is whether the centration and the aligned toricity is correct or not. If it is correct, then that's the job done. So this is the way to do an ICL the correct way. The pearls for good intraoperative outcome is the head positioning. You should have a good head positioning structure. The speculum opening should be adequate. These are myopic eyes, but then once in a while you might have an eye which is small, but still you have to have a good adequate space. No blocks. Let us not give blocks in these high myopes, because an inadvertent entry of a block into through the coats of the eye might be really a mess. Loading is very important, and we spend some time on the loading. The side port and the main port entries should be very adequate. Viscoelastic substances, the best viscoelastic is methyl cellulose. ICL insertion we dwelled upon. Tucking in the haptics is very gentle. You have to tuck the haptic. You have to have your spatula over the haptic. Do not try and tuck the haptic before you have negotiated to the end of that haptic. So your spatula has to go right in, tuck it, and let go, and it goes in very smoothly. Orienting the toric IOL we have spoken about. Irrigation aspiration, you need to take out all the methyl cellulose, which is very easy, and you need to hydrate the ports. Post-operatively, you need to check the status of the cornea. You need to see the angle of the anterior chamber. You need to see the toric positioning of the marks. You need to see the vault, and you need to see the intraocular pressure. If the vault is not the right vault, if it is too low, you have a chance that there might be a cataractus formation. So here you have to be very judicious. If it is just about 100, 150 vault, you have to see this patient time and again, maybe 3 months to 6 months. If you have a vault which is over, that is, say, about 1,000 microns, this patient needs to be washed again extremely well. And these patients might develop an intraocular pressure rise, and then you have to take a call. 2 things that you might have to do is first attempt a PI and try and see that if the vault is still the same, but is not occluding the angle of the anterior chamber, you have to do a good gonioscopy to assess it. And the other thing is, if the intraocular pressure is increasing, that means there is occlusion of the angle of the anterior chamber, you might have to explant the ICL and put in a fresh one. Thank you very much, and these miles and miles of smiles are there for all our patients who undergo this surgery. Thanks a lot.